Sure, Patiban.
Very good evening to everyone and welcome to the Medicine Forum. It gives me immense pleasure to introduce Medicine, a platform that has rapidly grown to become a trusted educational partner for medical students across India. Our mission is simple to provide accessible, high quality educational resources to empower students to excel in their academic and professional journeys. With a vibrant community of more than 23,000 subscribers in YouTube, Medicine has made a significant impact in areas like clinical case presentations, exam series, MCQ discussions, career guidance, skill development, etc. We are constantly evolving to meet the needs of our students, whether they are preparing for competitive exams like NEET PG or seeking to build a strong foundation to their medical practice. One of the things that makes medicine stand out is our commitment to mentorship. While there are numerous platforms offering medical educations, medicine uniquely emphasizes the personalized mentorship. We aim to provide students with daily guidance, one to one support, and practical insights that go beyond textbooks, helping them build their confidence and clarity on their career paths. So, as we approach in the part of our medicine journey, the World Diabetes Day, we are reminded of the importance of awareness, education, and collective effort in combining one of the world's most pressing health challenges, diabetes. This year, we are excited to present a special lecture series dedicated to deepening our understanding of diabetes from its physiological and biochemical foundations to its management and complication. The World Diabetes Day is more than a date on the calendar. It is a global call to action, and diabetes affects millions of lives, impacting not only patients but families and communities. As the part of our CME program, we are having our seventh session today. Yeah, it will be taken by our most respected Dr. Aditya sir on DKN and hyperosmolar hyperglycemic syndrome and acute emergencies. Dr. Aditya is a consultant physician in Panimala Medical College. He is the principal investigator in project collaboration with Mayo Clinic, USA, and Florida. He has a big list of achievements in his back, so it is very difficult to introduce him in this short period of time. He's a Chennai APA member, as a World Medical Association member. He is also associated with Mayo Clinic and worked at Tata High Range Hospitals, and followed by he worked as an assistant professor in Dr. Patnam Mahendra Reddy Institute of Medical Sciences. So we are having a very special guest today. Thank you for accepting our invitation, sir. It is an honor to have you here. We can start the session without any further delay.
Thank you, Patiban. It was wonderful hearing all these words, and thank you so much. I always have pleasure in teaching the UG and PG students, and which is my main point because I love students. I insanely love students because if you teach a student properly, 1,000 patients will be saved. That is what my chief in GH used to say. So let's start. Okay. So today topic is very close to my heart. That is hyperglycemic crisis. In hyperglycemic crisis, we have these two things. That is DKA and hyperglycemic hyperosmolar state. When you go to Harrison, it will say that honk, hyperglycemic non-osmotic ketosis. But why I have introduced it as hyperglycemic hyperosmolar state is in US and in recent trends, we have seen that hyperglycemic hyperosmolar state, they can have ketones. So that's why honk is not used. So that's why students, please remember, use the term as hyperglycemic hyperosmolar state. So let's go into it. So in this presentation, I want to focus on hyperglycemic crisis like DKA and hyperglycemia hyperosmolar state. And I want to tell you about the recent trends, pathophysiology, diagnostic criteria, treatment strategies, and its importance prevention. Already I started the recent trends telling you the latest term of it. So please, here you could have seen it. In the recent articles, they have given that non-ketotic hyperosmolar coma. So I want you to stress it as hyperglycemia hyperosmolar state. And whenever you see hyperglycemic states, you should deal with diabetic mellitus, stress hyperglycemia, drug-induced hyperglycemia. In drug-induced hyperglycemia, usually during the COVID time, when I was in GH, we used to see the plenty of the cases which have the steroids. So steroids are also can cause the drug-induced hyperglycemia and other ketotic states. You should know is the starvation ketosis and alcoholic ketosis. And other metabolic states like hyperchloremic, normal anion gap, renal tubular acidosis, rapid large volume saline infusion, and high anion gap metabolic acidosis like lactic acidosis, LND type, salicylates, ethylene glycol, methanol, propylene, and renal failure, and drug-induced acidosis. So when you take care of the hyperglycemic crisis, whenever you will see the thing which the students usually make mistake is they categorize it. Like they say it is DKA, HHS. But please remember there is a mixed type that is DKA and HHS. There could be the mixed type which you should see. So always it is like a precision medicine. Everyone is atypical. Like my shirt can fit for the another one and your shirt can't be fit to me. So everything should be the tailor made. So please remember, don't make it just like diagnosis as DKA or HHS. In GH, we have seen plenty of cases which have a mixed cases, and it requires just a tactical, small, a pinch of thing to be changed. That's it, and which will make your treatment to be fine. So always, 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 first is pathogenesis. Whenever you're dealing with pathogenesis, I have the plenty students telling me that, sir, DK and HHS both have same thing, like insulin deficiency and increased counter-regulatory hormone. Then why we are worried? That tells me that they have not read properly their physiology. Because in physiology, in Ganong, it is clearly given, like DK indicates severe insulin deficiency, whereas HHS is driven by the volume depletion. Okay, very, very important point. You would have seen this chart and everyone gets confused. Oh my God, what is this? What is this? Simple. Absolute insulin deficiency, relative insulin deficiency. In absolute insulin deficiency, what will happen? You will see increased lipolysis. You will see increased fatty acid to liver. You will see ketogenesis will increase and you will see the increased ketoacidosis. Okay, so there is counter-regulatory hormone. But when there is relative insulin deficiency, usually absent keto. This thing will confuse you always. So what I will show you, I will show you a one beautiful chart. This chart will clear every confusion you have regarding DKA and HHS. So my dear students, if you are there, please concentrate on this chart and at any time you can interfere me because this chart is the master map of this topic. First, we will spend few time on this thing. Whenever you have a patient with DKA, what will happen? There will be there will be insulin deficiency. So there will be no glucose absorption into the muscle and fat cells. So what will happen? There will be increase in the counter regulatory hormones. There will be increase in the counter regulatory hormones. So patient will have polyphagia. So once the patient has polyphagia, there will be the release of the free fatty acids because it requires the energy. So there will be hydrolysis of the free fatty acid in the liver. So what will happen? There will be acetyl-CoA and there will be ketone bodies. So this will cause increase in metabolic acidosis. Then you can ask, sir, why in case of hyperosmolar state there is no there? Hyperglycemia, hyperosmolar state, why there is no ketosis? For that also I have answer for you. Because there will be relative insulin deficiency. Relative insulin deficiency is there. So what will happen? There will be decrease in the glucose absorption. So the patient will have cell still need more energy. So there will be increase in the catabolic. Here, what is the difference? You will have hyperosmolar state. How you will have hyperosmolar state? You should see for hypernatremia. I have seen plenty of patients. How they will present? Delirium, lethargy, seizure, stupor, coma. Immediately, the junior doctor will say, sir, we should give anti-seizure medication. I will say, you should first correct the fluids. Always remember, in case of DKA and HHS, always you should correct the fluids. That is the first thing you should remember. Okay. And sodium. Whenever you see sodium, please remember, For every 100 increase in the glucose, sodium will relatively increase by 1.6. Suppose the patient RBS is 500, means after 100 it is increased by 400. 1.6 into 4, 6.4. So minus 6.4 you should do. Suppose sodium is 150, his normal value of sodium is 144. It is not 150. His sodium value is 144. That thing you should remember in your mind. Okay. So this is how your style will occur. This chart is very important. This has been addressed in the PGI Chandigarh many times. This thiolase, how it will come? Acetyl CoA. Then you'll get acetyl CoA, HMG CoA, acetoacetate. This acetone is what you will feel, the breathe-in pattern. Then beta hydroxybutyrate, acetoacetate, and acetyl CoA. This is the simple chart. That's it. Then I told you students, there will be overlap. Never label one thing as HHS, never label one thing as DKA. Always look for the hybrid pattern. That is, it can have both HHS and DKA. Please remember, never a patient of DKA should die. Please remember, it is a reversible disease. If a patient of DKA is dying, it is the relative inefficiency of the doctor. Never a DKA patient should die. Okay. Next, how can decay develops over the hours to day? Usually the patient will be alert. Then what about HHS? I told you it is increased serum osmolarity. So what happens? The patient will have confusion. Change in cognitive state will be there. And in decay, there will be kusumal respiration. I told 1/3 of the patient will have hybrid pattern. DKA and HHS presentation will be there. So, okay, what is diagnostic criteria? My dear students, please remember, whenever you put DKA, you should remember this slide which Dr. Aditya has told you. Mild DKA means more than 250 with pH 7.25 and 15 to 18 variable is there. Please remember how is the alert pattern. Always remember your decay treatment is over only if anion gap is normal. Unless your anion gap is normal, you should never say that your decay treatment is over. Please remember, whenever you should diagnose decay, you should say glucose GRBS more than 250. pH is very important. Why I'm telling pH? If pH is less than 7, I should give bicarbonate infusion. I should give bicarbonate infusion. Please remember, in DK, whenever you are giving treatment, don't jump on the insulin. First, give the fluids. Why I'm not telling jump on insulin? Unless you check the potassium. Unless you check the potassium, don't give the insulin. This is very important treatment protocols. Don't worry by seeing this chart. Very simple. Whenever you see the decay, first IV fluids, then check the urine output, check the ABG, look for the potassium. If potassium is less than 3.3, hold the insulin and give KCL. And then give the insulin 0.1 units per kg. Then infusion. When it reaches the 200, then you change it to the rapid acting insulin. And when is the resolution of DKA? When is the resolution of decay? Only when anion gap is normal. Only when the anion gap is normal, you should say that decay resolution has occurred, not with the glucose normalization. Only with the anion gap normalization only, you should say that decay has normalized. And when you will give bicarbonate, when pH is less than 6.9. Okay, and when you will see HHS guideline, Aditya sir has told you, whenever you give insulin, always check for the potassium. And first you should give IV fluids. IV fluids are very, very important whenever you are dealing with the HHS. First give IV fluids, then stabilize the insulin, potassium. Three things in HHS: IV fluids, insulin, potassium. IV fluids, insulin, and potassium. In DKA, pH is very, very important. Unless anion gap is normal, your DKA treatment is not over. Okay? Okay. Now, sir, I have hybrid. What I should do? When you have hybrid, very, very simple thing. Osmolarity should be reduced. IV fluid should be given. Insulin optimization should be done. Like this is the thing. Okay. First, whenever HHS and DK, please concentrate on this slide. HHS, the patient will have osmolarity greater than, sorry, HHS, the patient will have osmolarity greater than 320, increased natremia, plasma glucose will be more, and there will be absent ketonemia. And DK, there will be in pH less than 7.2, bicarbonate less than 15, anion gap. There will be increased anion gap in DK. And how you will settle? Always, always, always fluids. Then, if family history of type 2 diabetes is there, long lasting polyuria is there, obesity is there, clinical signs of insulin resistance is there, neurological symptoms is there, means HHS. HHS. HHS means always you should settle hyperosmolarity. DKM means you should look for anion gap. That's it. Very, very simple. Then, why insulin is important? In DKA, insulin will drive glucose into cell. So, hyperglycemia is treated. Drives potassium into cell. Hyperkalemia. Anabolic state is treated. And it will blocks fat breakdown. Fat breakdown block paniachna, free fatty acid production is treated. Then it blocks the protein breakdown. So, keto acid production is treated. Then what are the complications? Aditya sir has always told you, hypokalemia. Please, my dear students, please remember, whenever you are giving insulin, potassium should be more than 3.3. If it is less than 3.3, you should give KCl infusion, then only you should start insulin. First thing is IV fluids, urine output. IV fluids and urine output. When the DK treatment is over, when you will say, when anion gap is normal, then only you should say DK treatment has been addressed. Okay. What are the complications? I told you. Hypoglycemia, which is very easily to be treated. Hypokalemia. Normal anion gap, no problem. Normal anion gap, don't. I am worried about thrombosis. Thrombosis is there, you are suspecting low molecular weight heparin. That's it. Then cerebral edema. Please remember, cerebral edema is very, very important. You should look for Glasgow Coma Scale. You should look for the pupils. Osmotic demyelination syndrome. Never start sodium treatment immediately. Hyponatremia patachi. Ayo, don't worry. Treat the patient symptomatically. First, give IV fluids. Acute kidney injury. Why acute kidney injury will occur? Because renal hypoperfusion. What you should give? You should give fluids. Fluids. Sir, the patient is in heart failure. How should I give fluids? No problem. Give the fluid challenge. Look for urine output. Still fluid is not there. Look for the IVC. IVC is collapsing. Give the fluids. IVC is dilated. Monitor the fluids. Look for the output, give the insulin. Very, very simple. DK treatment is very, very simple. How you can prevent the DK? By properly addressing. Always, whenever a DK patient comes, you should look for the infection. Pneumonia insulin correct patient erkarara. Insulin is being taken properly. You should look for the cardiac status. All these three should be addressed properly. And I told you how to look for the DK, very simple thing. Very, very important. SGLT2 inhibitors induce DKA. Nothing. Simple. SGLT2 induce DKA, give the fluids. It will settle. With my vast experience in ICU, I'm telling, don't worry. Just give the fluid. No patient should die because of DKA. Then this is the treatment plan. Sir, now I treated the patient very happily, sir. How I should take care of the patient? You should look. Is there risk of hypoglycemia? Is there anything is there? Should I continue? Please remember, all the patients of DKA don't continue SGLT2 inhibitor. All the patients of DKA look for infection. All patients of DKA look for the MI, whether the patient had any MI. All patients of DKA look for the pancreatitis. All patients of DKA, whether the patient is taken properly the insulin or not. Very, very important. No patient of DK should die because of improper treatment. Management strategy for special population. Special population లో ఎరుకుమోదు what all things. Frail, nothing. Simple. Don't complicate. In ICU, urine is the gold. How much is urine output is there? IV fluids. In ICU, sit to the next to the patient every half an hour. Sir, pulse, BP, respiratory rate, temperature, saturation, urine output. Everything is going okay. You are doing wonderful treatment. Okay. Pulse, BP, respiratory rate, temperature, saturation, and SpO2 is okay. Urine output is okay. You are doing wonderful treatment. Don't worry. You are in the correct direction. Anything is altered, think what mistake I am making. SGLT2 inhibitor in DK, please don't give. Kidney disease, don't worry. Slowly and gradually you give. Pregnancy, very, very important. Whenever you are dealing with pregnancy, treat properly. Pulse, BP, respiratory rate, temperature, saturation. Every half an hour you monitor. Output is coming, okay, you are going in correct direction. Output is not coming, rethink, ask the help, contact the expert. Anytime I am there for you, anytime, because I don't want any DK patient to be in the terminal state or in the death state. All DK patients should recover. Till now I'm telling, in my GHPG days, once one DK patient died, that's it. My chief scolded me whole day. He told, Aditya, please remember, no DK patient should die. From that day to now, from 2014 to now, not even single DK patient has died in my hands. Whatever might be the condition, all patients have recovered. So, DK should be addressed properly. What important thing I told? Unless anion gap is normal, DK treatment is not over. Okay, and in COVID also you should anticipate the risk, because whenever you are giving steroids there could be hyperglycemic state. But what I told you, you should treat fluids. IV fluids are important for me. For me, CBG doesn't matter in the acute treatment. For me, the most important thing is IV fluids, IVC, urine output. And we can conclude by telling that effective management and prevention of hyperglycemic crisis is very, very important. My secret tip. What is my secret tip? I have treated DK properly. Sir, the patient is going home. What I should say? Whenever you are dehydrated, my dear patients, please take electrol. Very, very important. Tell the patient to be on electrol whenever they are dehydrated. So, with this thing, I kept it very crisp and very neat for you, so that in future, any DK you see from India to Antarctica, you should be able to stand and say, okay, Aditya sir has told me, I have seen a patient of DK. Now CBG is high. How should I treat? I will not worry about the CBG. I will start IV fluids. Then I will check pulse, BP, respiratory rate, temperature, saturation, ABG, urine output. Okay, everything is coming. Okay, now I'll check for potassium. I will not rush for the insulin. I'm checking the potassium. Potassium is less than 3.3. I will give KCL. Potassium is more than 3.3. I will start insulin. Every half an hour, I'll monitor. I will check the DKA. DKA treatment is over. Oh, still HHS is there. I will look for the serum osmolarity. I will look for hypernatremia. I will settle the cerebral edema. Osmolarity settled. DKA settled. When is DKA settled? When the patient is taken orally. When anion gap is normal. When glucose came less than 200. Glucose less than 200 with not anion gap normal. DKA not settled. Glucose less than 200 with anion gap normal. Patient taken orally. You have treated the DKA successfully. That's it. With this simple thing, I hope you understand. Okay? Thank you.
Thank you so much, sir. I call upon Dr. Raghunandan Ramanathan to deliver the vote of thanks.
Thank you so much, sir. I think after this, I think of half an hour, within this short period of time, this was like a fantastic, energetic discussion, sir. I
Thank you,
think
Raghu.
from the starting of the session till this 26 minutes which we have discussed so far, I don't think so anyone would have just slipped off their concentration in this uh, full discussion. Such a energetic and such a wonderful discussion, sir. I think we this topic, as it shows the importance acute emergency.
Exactly.
This talk has been justified with the entire guidelines for the students, for the general practitioners, and for all the people those who have joined with us today. And mostly, as I also emphasized before the starting of the discussion in the participants group, most of the intern after the completion of internship, probably we know that there are lots of private colleges where the cases are not sufficient enough for them to learn, and but once they come out of the college, they are
Exactly.
forced either to go for a neat PG preparation or for a casualty medical officer duty, because most of the colleges now they have junior residents as postgraduates, and they are not recruiting a MBBS student. So when they
True.
sit into a casualty medical as a casualty medical officer without knowing these issues, they are fully dependent upon the PGs, and of course PGs are dependent upon the APs, and this cycle goes on. So this motto of the entire series which we had so far for the past 8 days, and we have 2 more sessions for the next 3 more sessions for the next 3 days. The motto is diabetes is something that every OPD, every medical officer, those who are sitting, is going to get. So these people, they have to know the effective management strategies. And I hope so today's session is going to be an eye opener for everyone. We will also promise to every registered participant that we will make it into a shorts and reels, and we will also post it in the Insta and as well as the YouTube, so that every
Sure, Raghu.
individual topic at a short period of time you will be able to learn. So even if you have joined at the mid of the discussion, I recommend you to go back, see from the first, because such a energetic, such a talk, which every point
Thank you,
is
Raghu.
very important for from exam point of view. And sir has keep up the timing within 20-25 minutes. He has delivered the entire core topic. Thank you so much, sir. And
Thank you, Raghu.
I would like to thank all the participants as well as the team behind the work who have been constantly doing for the past 8 days. And we have 3 more days. And I think this session will be like covering the entire discussions and entire agenda which we have. Thank you, Parthiban, and you can conclude.
Thank you so much, sir. And Dr. Aditya, sir, it's a pleasure for us to have a session with you. We are hoping for many more sessions in future.
I love students like anything, Parthiban. My passion is my students. I love students like anyone. Anytime, anything, any students request, I am there. Definitely I am there. Because I love students. I love teaching them like anything. I was very passionate when I was in GH Kottayam. So that's why when
Actually, that was evident, sir. Your love towards teaching, it was very evident during the session.
thank you, Raghu. Thank you, Raghu, and thank you, Parthiban. Thank you.
Thank you. We'll end the live now.
Thank you.
live end பண்ணியாச்சு.